All right. Well, I would like to introduce our three speakers, Merida Odiorne with J Short Insurance, Kristen Hoff with Transparent Insurance Solutions, and Kevin Heckman with Mountain West Insurance. And they are all very highly qualified local health insurance brokers who always teach me so much. I learn so much from them, and really excited to have them join us today. So I will just give a quick introduction about how we are here today and why am I moderating this call. So Local First partners with Peak Health Alliance, and we've brought in greater competition to the market by sponsoring a health plan known as Elevate Health Plans, which is which is underwritten by Denver Health Medical Plan. It's a nonprofit, and they've now been in our will have been in our market 3 years, but have been in the Colorado market for over 25 years. This webinar is not about that, but I did want to give you an introduction and help you understand Local First. Our role is to partner with Peak and make that plan available, because when we bring competition to the market, studies show, and a study was done actually on Colorado to show that actually brings the premiums down for everyone. So whether or not you buy Peak Health Alliance plan, you're going to benefit from the work that we're doing, and that's great, because that's the goal, is healthcare affordability so that more of you can afford health insurance. You've all probably heard of Obamacare, the Affordable Care Act, which was enacted in 2010 and went into effect in 2014. And that provides subsidies for people to be able to afford their health insurance. That, again, is not what we're talking about today. But in 2016, under the Trump administration, something called ICHRAs, Individual Coverage Health Reimbursement Arrangements, were created. And they really work hand in hand with the Affordable Care Act. And so I like to say it's a bipartisan solution to our problems, because they will allow for people who don't want to buy their own insurance, who are employed, the employer to help them to do that. And our experts here today will explain how that works. You can see the questions in the chat that they will cover. And then when it's a good choice for a small business, other alternatives you might consider, and then they'll each just get a chance to talk about their approach to working with their clients. I'll ask to save the questions. I think we'll do a short little time for questions after each of those 4 topics. But then if you have other questions that aren't related to that topic, I will ask you to hold them till the end, and then they can answer those questions all together with you as well. So with that, I am going to ask Merida to begin, and the other brokers can chime in after she has had a chance to speak about how does an ICHRA actually work for a small business. Merida?
Hi, good morning, everybody. Okay, so ICHRAs allow employers to pay for individual premiums, individual coverage health reimbursement arrangements, and ICHRAs health reimbursement arrangements have been around for a really long time. It's the IC part that's relatively new. And for whatever reason, in our neck of the woods, in our region, they're substantially more competitive than true small group rates. They allow individual plans to pretend like they're group plans. You set a waiting period. You still get the tax write-offs for offering coverage. Both the employer's portion and employees' portion are pre-tax. And it allows employers to basically set a bucket of money that people have to go shopping with on the individual options. And people can choose, staff members can choose any plan they want from those plan offerings, which this year and next are 3 different health insurance companies, 38 plans to choose from. So employers get to offer a benefit, but don't have to choose 1 or 2 or even the same company. Staff members can go select what works the best for them. There's also a bit more flexibility in, we don't have like participation requirements, and I've found them to be pretty user-friendly. There's a bit of a heavy admin lift on them because everybody's set up on an individual plan, and you don't just have one group plan. Everyone's picked their plans, right? So it's a selling point. Anyone can pick which plan they want, and it's something that makes it overwhelming for staff is anybody can pick which plan they want. I can just keep chatting, but I'd love to hear Kristen or Kevin chime in as well.
I am a big fan of them. Like you said, each one can select their own plan. So when you're dealing with a group of five or small group, especially like 5, 10 employees, if the employer picks one plan, two plan, you're not going to make all the employees happy. A lot of times you have a young 22-year-old that's healthy that just wants something to cover the urgent care and accidents. And then you got a 55-year-old that's diabetic that needs a lot more coverage. And that's where it's really shines is we can tailor it to each employee to what they really need. Or if one employee has a doctor that only takes Rocky Mountain and the other employee has doctors only take Anthem, or they want something that covers more specialties in Denver, we can tailor that for them.
Yes, I agree. Everything those two said and more. The personal choice is the biggest advantage for small employers that want to contribute something towards health insurance for their staff. I will say a lot of employers that I work with find the stress on the front end of setting up an ICHRA a little bit lower when they can just say, this is the dollar amount that I have as a business admin to support benefits in all capacities. What can we do with this budget? And so sometimes it's easier to work from that and work backwards and see what we can do to meet the desires of the employer to want to contribute something towards their staff. So the ICHRA does allow for that because you can set up the ICHRA to contribute a flat dollar amount per person or a percentage based on what am I trying to say, you guys? A metal level plan based on a benchmark plan. So that's also a really attractive thing for small employers.
All right. Well, that's a really great introduction to ICHRAs. And I want to just follow up and ask if you would just explain a little bit more about the mechanics of that. So let's say an employer decides an ICHRA is right for them. How would you go about setting them up on an ICHRA program?
Yeah, there's a bunch of different ICHRA platforms out there. We've It's kind of an overwhelming amount. My office is settled on ICHRA systems. That's just one that we're kind of moved into and comfortable with. And so the platform ultimately has the legal beagle and the links for everything and the documentation and the renewal process. And so we load a group in, which is really easy. I just did one this morning. It's like your address, your tax ID. I think it's kind of the big decision there for employers, just like Kristen was talking about, is their employer contribution strategy, whether they want a flat dollar contribution or a percentage of the benchmark plan. And then it creates a link and a username and a password for employees to go shopping. And it does the math as far as how many times they're paid, what comes out per paycheck, to give some plan details. In the back end, we take your company banking information so that I can establish auto drafts for each of the different individual policies with the different carriers. Implementation, at least like structuring the container, is pretty straightforward, but the administrative lift is like making sure everybody gets settled in and that we do everything in time and leave plenty of time for people to cancel their old coverages. Yeah.
Great. Kevin, would you add anything?
Yeah, and yeah, like Meredith said, is how much the contribution. That's probably the most confusing thing for an employer. The question I get asked is, how much is it going to cost me? Well, I kind of work it backwards. Like, what can you afford? And I'll work the numbers to make it work for the employees, and they pick a plan, and it's auto drafted out of their account, or off their paycheck, the difference. And like Meredith said, you can do the straight flat amount for each employee. And I generally try to steer companies away from that because, in my opinion, that's not fair because the younger employees are going to get almost all of their plan paid for. And then you start dealing with employees in their 50s and 60s, and it's not going to pay much of their premium because with the ratios, it's a 3-to-1 from age 20 to age 64. So someone 64's rate's 3 times higher than someone 20. So if you have a flat amount, it can be pretty unfair. So I actually have a software where if the employer says, "Hey, I can afford 4,000 a month," and here's my list of 7 employees or whatever. I punch in all their dates, and my software will tell them exactly how much each employee would get based on that 3-to-1 ratio. And I think that's the most fair way of doing it on there for especially if you have more or a few older employees. That's usually the biggest thing I run into with implementation is just trying to figure out what the employer wants to pay.
Yeah, I agree. I do see that too. I also try to steer my businesses away from using a flat dollar amount. I do have one that does do that. However, the equitable issue comes up. It's not equitable. It's equal, but not equitable because everyone has their own age-rated pricing. So when we're looking at trying to make things fair, that topic does come up quite a bit. The other advantage of implementing an ICHRA is for employers that have Medicare beneficiaries on their staff. That is a big piece. Employers still want to contribute something to Medicare beneficiaries. And in the traditional group world, that's not allowed. But under an ICHRA, we can set up contributions towards either a Part B premium and a supplement, standalone prescription drug plan. You know, the employer has the flexibility to contribute something for those folks. And so that's of huge value to a lot of employers that, have longtime employees that have served their business well. So, in addition to everything those guys said too, it's really important, like Merida was saying, to make sure that all the premiums are actually getting drafted out of the employer account because these are individual plans. So when brokers like us set up the application, the enrollment, and the automatic payroll deduction, premium deduction pulled out of an employer account, if that employer is not watching every single month and there's a discrepancy, because we as brokers will not see that. They have to tell us, hey, this premium didn't get drafted. We won't know that. So that is another educational piece that we all try really hard to make sure that our employers understand, because if a plan cancels, it becomes pretty difficult for us to get it reinstated with the same carrier.
And same, I tell the employees too, and I think the
Yep.
standard email from ICHRA systems that I think we all pretty much use,
Yep.
it says right in their email, if you get a past due notice or any kind of notice, let either your employer or us as a broker know right away.
Right. And people don't always open their mail.
No, exactly.
So it's very important. That piece is a really, really important piece.
Well, I will just say that I have worked with all three of these brokers to facilitate when they have issues with Elevate Health Plans in particular, is our partnership, and I can say that they are fantastic at solving their problems, and we try to get back to them with Elevate Health Plans, and I can't speak for the other health plans, but their advocacy really makes a difference, I think, for making an ICHRA work, and I really appreciate that they stay on top of things for their clients. I want to just tease down a little bit more because I want to make sure that employers who are on the call today understand, is there a minimum amount that they would have to contribute to make this work when they're deciding their contribution levels?
I keep going first. Kristen, do you want to take it?
Want me to take it? Yeah, I mean, there's no minimum really required under an ICHRA. The establishment of the ICHRA is the mechanism that we needed to have in place that allows employers to pay for individual policies. Up until then, employers were doing it, but it wasn't legit. So now that we have the ICHRA, we can structure it however is suitable for both ends, the employer and the employee. What we really don't want to do, though, is prevent individuals from receiving tax credits if that's happening. So to have a conversation about the goals of the business, the funding of the business, what the capabilities are in the budget, what if the employer happens to know other coverage that employees currently have, the goal is to make this work for everyone and find a win-win. It's certainly not to make things worse. So every situation is going to be different.
Yeah. And that's what I run into, especially with the lower contributions, is you may not be helping some of those employees that right on the border of getting tax credits through Connect for Health, because there is the IRS calculation of, if the employer offers affordable health insurance, you get tax credits. So if you offer, it's just a fine line there of helping some of the employees, and some of the higher paid employees may not really care if they don't or do have a lower reimbursement, because they still get all the tax savings of having it pre-taxed off their payroll. So yeah, it's one of those fine lines there is you have to decide how much you want to pay, and not really hurt some of the employees that could get more help through Connect for Health.
Mhm.
I also think, especially in virgin groups, if you don't offer coverage now, everybody sort of has something going on for insurance. And if your intention as an employer is to offer benefits, it's important. You're trying to keep people and retain people. You can't find one answer that works for everyone unless you're going to come and pay 100% of the premium. I mean, that's hard to beat, but most organizations can't afford that. But ultimately, what we're all alluding to here is, if you have access to group coverage, you don't get to go over to Obamacare and get a subsidy. The affordability is about 9% of your income. But Doug, there's not a minimum, and there is a strategy in which really higher income earners that will not qualify for a tax credit, which, by the way, for next year is like, if you make more than $62,000, no more subsidy for an individual household. If your staff's above that limit, and even if you contributed, this is an extreme amount, but $1, okay, the employee's portion of their premium is pre-tax. So there's a value of offering any amount to staff, especially the over income staff, because of the tax value alone. I don't have any groups doing that. I took it to the extreme just to say there's just sort of different ways to maneuver this. And then I think another important component is these classifications. So in the old small group days, you could do this sort of management only carve out. We can't do management only carve out on an ICHRA, but you can offer it to salaried versus hourly, part-time versus full-time, certain different geographic locations. So there's still a distinction for who you're defining as benefits eligible. And if it's like just your full-time people, and you define full-time, right? So if I say 40 hours and someone works 35 hours, they're not benefits eligible. And those people could still go see what they get through Connect for Health Colorado as far as tax credits are concerned. So I think this is I think it's really fun. Actually, you guys are both on this side for my screen here, but listening to your thoughts on it as well. We're all saying the same things, and just ultimately like the little nuances that are built in to deciding in the end, is this the right move for your business?
Yeah. Boy, I always learn from you guys. I just really appreciate you. Well, let's move into the second question, because you really teed that up nicely, Merida. When do you find that an ICHRA is a good choice for a business versus a traditional group plan? And when it's not, right? Are there kind of markers or types of businesses or certain kinds of situations that really you've seen in your experience that kind of point toward one or the other?
Kevin, you want to take it away?
Yeah, Kevin.
Okay, yeah, so yeah, right now, I mean, it's a lot rate driven. The traditional small groups, 30 to 40% more expensive right now. And of course, next year it's going to be a little bit different because rates are changing different rates. But the big thing I stress is on traditional group health, you have different networks you can offer. You can offer a PPO, or you can offer the enhanced, like a pathway with Anthem, where you still can get some out-of-state coverage. And traditionally, the small group plans have more options, which typically are a little bit richer in benefits. So that's kind of the trade-off with the ICHRAs. Okay, you may not have as quite of a rich plan. You might have a higher deductible or higher out of pocket, maybe not as good of a network, but you're saving 30%. So that's something I definitely stressed to all these groups, like what you're doing there. And if you have out-of-state employees, I have one group I'm working on right now. They have an employee that's literally 2 miles on the other side of the state line. So with the ICHRA and all their doctors here in Colorado. So they kind of have to use a traditional small group for that employee, because if they get a plan from that state, it won't cover the doctors here in Colorado. So that's one thing, is out of state um, uh, employees too. Um, Small groups, and that's kind of the main thing I run into, is just the cost and the different plan available.
Me too. Also, if there are staff members with college students that don't live here, like you're saying, staff members is a consideration, but so are the dependents. And sometimes with the higher earners, they've got, maybe college aged kids that are in Arizona or Washington or Michigan or whatever. And so in that case, that becomes a little bit more difficult. We can still work with that scenario, but it's something that the employer does really need to consider. What I've found is groups that have been offering benefits for a number of years and they've traditionally offered something very rich, the ICHRA may not be a fit. They should certainly know about it and understand all of their options, but it might be like a wah, wah, wah kind of feeling when they understand the main differences, like Kevin was saying, between the network accessibility and the coverage of availability. For groups that are in Colorado, even if they've offered plans, but the policies have kind of focused on Colorado networks, it could work great. It's just very specific, case by case specific. And the three of us do extensive intake interviews to understand who we're talking to and what we're dealing with and try and make it a win-win.
Yeah. And the other thing is participation. I didn't mention that, is, traditional small group, you have to have usually 50 or 75% participation. Now, I have some groups where there's only like 5 participating out of way more employees. So they're kind of stuck with an ICHRA because they aren't going to meet those participation requirements for traditional small group.
Yeah, I think you guys nailed it. I mean, when is it a good choice? Like Kristen mentioned, right? It should be an offer on the table.
Mm-hmm.
And if you're working with a broker that hasn't talked about it or doesn't want to deal with it because there's kind of administratively a heavy lift, it's worth your time to explore it as an option.
For sure.
Yep.
Yeah. If your local broker isn't going to talk to you about it, I guarantee someone from out of town, Denver broker, will be talking to you about it.
Right. Well, that's excellent. Merida, is your client on the call?
Oh, did you send her the link for that? We did.
Yes.
Let me, I don't. Talisa, are you on here?
Well, that's okay. I wanted to share then that I have heard a story of a business that did switch from traditional to ICHRA, and they did a lot of communication around that. And I think when they made the switch, they did, their situation might have been they didn't have a super rich group plan, and then they did a very generous contribution through the ICHRA. So the step from one to the other didn't seem like a huge cliff. And they were able to share some of that savings and the premiums in the program with their employees. So the employees really benefited from that as well and could use that extra money in different ways. So I think it's worth thinking through, how that transition could work if you are thinking of transitioning from one to the other.
There are some really significant cost savings when these rolled out, right? Like substantial. But it's funny because then people get used to it, and then we're just all presenting, by the way, 30% rate increases to our ICHRAs for 2026.
Right.
And it's still more competitive than through small group platform. Mm-hmm. So I think it's a good reminder of they've been saving a whole bunch of money and like still are, even though it's a big rate increase.
Yeah. Let's actually, since you raised that, let's talk about that a little bit in terms of the rate increases. If you could just elaborate on what's happening in the market this year with premium rates. I know that they haven't been finalized yet for the individual market, but we know kind of a ballpark, right?
Right. So in the end, these are individual plans. So all of these ICHRAs, even though they're a group, are tied to the individual market. It's just a super interesting renewal period. We're on ultimately the third set of preliminary rates. The Division of Insurance did have carriers file this third set of rates in case Congress is able to come up with any kind of resolution here, but in the end, it's always down to the last minute before all of the approved rates are loaded into the state exchange's quoting system, and the subsidy calculators are up and running. So this year is just really, really pushing pushing the limit. The initial rate filings were in our area truly 38%. The House passed something with having to do with something called reinsurance and actually did bring the rates down a little bit. So instead of like 38%, it's like 30%. Which is just a really big hit. I would love to hear, I don't know, what you guys are, how you are communicating this to your guys' clients.
This is hard. This is really hard because without final rates, giving any initial information other than the parameters that we know for sure, in my opinion, can create a lot of unnecessary confusion. So there's a big bit of me that's like, come on, you guys, tell us which direction we're going. So when I say, except for the things that we know for sure, we know for sure inside Connect for Health, when individuals are applying for tax credits, if they undershoot their income at all by $1 and they receive too much federal assistance in the form of advanced premium tax credits, they will be paying all of it back when they file their taxes, not a portion. There's no longer going to be a cutoff like there has been since 2014. There will be major upset, in my view, from that. And so the most difficult is going to be working with self-employed people that really don't know what their income is going to be because they don't know what kind of accounts they're going to have, or they don't know what kind of jobs they're going to take, etc. We know that for sure. We know for sure that if you enroll in an individual plan that's bronze in the marketplace, it's HSA compatible, right? We know that for sure. What we don't know is what the increase is going to look like. I mean, we also know that people making 400% or more of federal poverty level based on their household size are getting no help. We also know that requirement to provide proof of income is going to be happening much more frequently, right? So those are things we know for sure about what's happening in the individual market. The other stuff is total speculation until we have firm numbers.
Yeah. And just so if anyone doesn't know, November 1st is open enrollment, and we will know hopefully by October 31st or November 1st those rates. They are really pushing it to the end this year. And it's unfortunate, but that's just because of all the changes that have occurred in the marketplace. Kevin, do you have anything more to add?
No, not really. It just, yeah, just a big unknown. And, like in past years, Anthem set renewal letters out like early September for next year.
Right.
And now these carriers and Connect for Health, they said they're not going to send any renewal letters out until like November 1st or 3rd. So I've been receiving a ton of emails from clients. Can my plan just auto renew? It's like, well, most likely it can, but I still want to talk to you because who knows what the rates are going to look like. So either way, you're going to want to talk to me. But yeah, none of us have any idea which clients are going to auto renew at this point, even.
Yeah. And I don't know if this will affect Colorado because we have our own marketplace, but I know one of the discussions at the federal level is if they do come to an agreement on extending the enhanced premium tax credits, which that they might take away out of renewal because they think that leads to fraud. Not going to opine on that, but that's just out there. I want to follow up on something that was said earlier in terms of how this works. Are there alternatives to either a traditional group plan or an ICHRA? Is there a third way here in the marketplace?
Who
Krista,
wants
you want
that
to
one?
start with that one? Yeah.
I kind of want to hear
Sure.
your guys' answers.
Yeah.
Sure. I mean, if a group finds true fully insured small group pricing to be unaffordable, we can certainly look at level funded if the group qualifies. So when I say that, those carriers will still look at the group's health as a whole, and they have a right to decide whether or not they want to extend coverage to that group. The advantage is if your group, looks like a favorable group for the carrier, the rates can be really attractive. And then you're still getting the benefit of offering a traditional group plan, usually with a better network, right? Maybe a national network, or what we're seeing pop up a lot now are reference-based pricing models, which are reimbursements based on a percentage of Medicare. So that's an option. If the group is even larger than that, we can look at aggregate only, which is kind of like level funded, or spaggregate, which is a combination. I only have one TPA that does that, but that's another option. But again, we have to have minimums as far as how many lives we're looking to cover. We also have to know the budget the employer has available. We want to know the needs of the group, like I was saying before, maybe, or like Kevin said, maybe an out-of-state employer, like I was referencing, maybe out-of-state dependents. We just want to be able to look at all available options for an employer. If the employer doesn't like any of those ideas for medical, it's still a benefit for an employer to offer a dental plan or a vision plan, or maybe a lifestyle, it's like an ICHRA, but it's for lifestyle things. That doesn't have the same awesome tax advantages, but if an employer wants to contribute something, they could set up something like that and tell staff, like, okay, I'm going to give you $1,000 a year or whatever, a quarter, maybe whatever it is, to spend at the gym or on a ski pass or on groceries or student loan payments. Like, the lifestyle options, the lifestyle kind of reimbursement options are open to the employer. Again, the tax savings isn't there, but who doesn't love to have help with stuff like that?
Right. So I want to just clarify too. Kristen mentioned something called level funded plans, and they are kind of in a hybrid category between being fully insured, which is the traditional way we buy insurance, and what's called being self-insured. And employers of a certain size can be what's called self-insured, where they're bearing the risk, and a level funded plan is kind of halfway in the middle there. Would one of you, Merida or Kevin, like to say more about level funded plans?
Yeah, so they're based on the health of the group and your group size. And when these first came out, you needed like 250 belly buttons. And so they've come down, 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 down. There's some carriers that will consider you like 5, although generally it's just not quite, like one person on one expensive prescription will throw that off entirely. But conceptually, it has the look and feel of regular insurance to the end user, and they have an ID card and network and copays or however the plan's structured. But behind the scenes, when you pay the premium, a part of it goes into a claims fund and a part of it goes to keep the lights on and print ID cards and process claims. And so ultimately, when claims come in, the money comes out of this claims fund. But if it's your low claims utilization for the year, you can get some of that money back. Generally, it's like credited towards future premiums. It's this like potential pot of gold. Again, it can be eaten up pretty quickly with claims, but if one person skyrockets and goes into really high claims, there's a stop loss carrier that takes over for the big stuff. And I have found that if you do have a higher claims year, when your group is up for renewal, they're trying to make up for lost time. So I've seen like 136% renewal offers. It used to be that you would have a penalty for switching back into small group. The carriers, remember this, could charge like 25% more, because
Yes.
the only reason you leave that is if it's not working well. And now that's gone. So if it fits your group, it's worth trying, knowing that this is like why brokers stay so busy. We have to assess annually, like, is it going well? What else exists?
Yeah.
What if we shift here? What are the needs of the group? By the way, we are commission people, so it doesn't cost anything extra to work with a local broker. And I found self-funded plans to be a good fit if for like younger, healthier groups ultimately. Yeah. Hello, Talisa.
So sorry. I'm so
Yeah,
sorry.
perfect timing. Yeah.
Thank you.
Yeah. What yeah, we ultimately wanted like a real life example of a group that it is on an ICHRA to maybe share experiences. Doug, do you have any prompting questions for her?
Well, thank you so much for joining us, Talisa. And if you would just introduce yourself and your business and just talk about how you came to the decision to offer an ICHRA and how it's working for you.
That sounds great. So my name is Talisa Flanagan. I'm the practice manager at La Plata Family Medicine. We have about 28 to 30 employees. I have an extensive experience in HR, have bought benefits for large, 700 employee organization groups to ICHRAs. And I had never heard about an ICHRA until I came to La Plata Family Medicine. So I can tell you it's been a great experience. It works really well for having such a small group of people. It gives more of my employees opportunities to get benefits, and it's incredibly easy. I think the hardest part is helping the employee get the right plan for them. And so Merida and them have been great about taking that kind of burden off of me. So long introduction.
That's great. Did you find when you went to the ICHRA that you were able to save money on that transition point?
I don't know that because I inherited the ICHRA, but I can tell you that I think employees, it's a reasonable cost for them,
Mhm.
and it's a reasonable cost for the employer. But I can't speak to whether or not they've saved money or not.
Sure. Yeah, I understand. And how about your employees? Can you share some of, without revealing any identities, like any experiences that they've had in terms of being able to pick their own plan? Do they like that freedom of choice? Is that a burden for any of them to have to decide?
Well, I think the good news is I don't have any feedback. So I think that I'm taking that as it's been a great experience for them because each individual gets what they need. Um, I think that just the fact that they can get insurance. So for a lot of my kind of like frontline staff, it gives them some affordability for them. So a lot of folks who can't get insurance maybe otherwise have been able to do it. And I think that's been a real benefit for them. I haven't had any complaints or, everybody's a little like taken aback by, what the current administration has done to our healthcare stuff. So we'll see what comes of that. But everybody still seems to be on board. They're not going to let that stop them from going forth.
That's great. Well, yeah, no news is good news, I guess, in that
Yeah.
situation, right?
Yeah.
All right. Meredith, do you have any other questions you want to ask to Lisa?
Well, I just on the broker side, right, we're ultimately not boots on the ground in client facing. It's different. So my admins and business owners and the people who are really interfacing with the clients, I love hearing the positive feedback about it. It's not always positive feedback. You're a really great communicator with your staff so that they know if they receive like a weird bill or you're late on your bill or something looks off, that they immediately bring that to you. I find that to be by far and away the biggest challenge. I am really curious to see ultimately when employees go shopping with this new rates with the rate increases, like who's choosing to stay. I would expect to see a lot of people changing plans, and so that might create just a bit of new ID cards and who moved where, what is the auto draft still happening? But in general, the answer is yes. The group saved a lot of money when we switched over to ICHRAs. But then years down the road, you think, oh, well, now there's this big rate increase. Where like, what else can we do to save money? And we've basically been exploring the options that Kristen was just discussing, which is kind of just what else is out there. Yeah. But it's so interesting to hear you worked with gigantic groups. Wow.
Oh, yes, came from a company. We own 16 different nursing homes in Oklahoma. So group health for, 700 people is a lot. And people, so even in that situation, like usually the frontline staff who have lower wages, still a group plan is out of their reach financially. So the ICHRA seems like, okay, you can pick and choose what you want. So you have a lot of flexibility. From the employer perspective, you also get to choose kind of like how much you want to contribute. And so I think that's really nice, because then you can kind of like see how it all went one year, and then you're not stuck. You can like make a different decision a little bit. We haven't changed since I've been here because the owners feel comfortable with trying to contribute to that. We're in healthcare, so we really get that more than most maybe, and we kind of understand it. And it's important to us to have that protection for our employees because we need them at work. And so it's a lot cheaper to pay the premium than it is to like train someone or whatever. So for us, it's an expense that's well worth it. And again, I just like the variety.
Do you have any advice for an employer that might be thinking about an ICHRA, Talisa?
I don't think that I do, and I usually have an opinion or advice on everything. But I think what's going on is that, I inherited it, I didn't know anything about it, and that Merida has made it, and Jay Short has made it such an easy thing that it's not burdensome for me. I don't have to spend a lot of time dealing with it. And I think that's probably one of the things that you'll learn from that, instead of having to get into the nitty gritty of trying to correct your bills and all of that stuff. I mean, it does happen, but it hasn't bubbled up that I have to deal with it.
Oh, that's great. Well, thank you so much, Talisa, for joining us and sharing your perspective. I'd like to open it up now to anyone else who's joined the call. If you have questions for the brokers, if you would just come off of mute and just go ahead and ask, that would be great. Or you can put something in the chat if you don't want to do that, or you can't because of whatever technology limitations you may have. Anyone have any questions?
I think we answered everybody's questions. That's all the answers.
Well, maybe while you're thinking, I will just ask the three brokers to go back around again and just share a little bit about some of the things that Talisa was talking about. How do you go about working with the client? Kind of what's your approach? And especially how do you interact with the employees as they're making their choices? Kevin, you want to start?
So, yeah, interacting with these groups, I do have an appointment with some of my groups where I'll just go to the employer each year and sit there for an hour or two and go through with each employee and make sure they have the right plan for the next year. I have other groups where they send them to my office on my regular schedule for open enrollment and go through what their needs are going to be. Another big thing I stress with these local businesses, and you're being with Local First, is I know Kristen and Merida very well. We're all going to take care of our clients. I stress don't go with an out-of-town broker that you're never going to see. I mean, not saying there aren't good ones out of town, but we care about our clients. We run into our clients at the grocery store. We want to take care of them. So, I mean, stress and doing it with a local broker.
Yeah, thanks, Kevin. Kristen?
I do the same thing. I find that some of my groups want me to make an appointment to come in and sit with the staff for 1, 3, 4 hours, to make sure that they're choosing a plan that's going to work for them for the following year. Um, um, other employers will have them call me to schedule an appointment on their own time instead of carving out time during employment hours, like during working hours. It depends on the type of business too that we're talking about, and some businesses don't have the time really to do that, you know, and during working hours. So often I'll give them weekend options, you know, outside of work. I'll carve out times for those folks, because open enrollment is, you know, as we all know, there's a deadline. I will say too that the education piece that comes up over and over and over that the three of us, I know, always really stress is about the communication, and please open your mail. But to employers as well, please let us know if you don't see a person's premium being drafted out of the checking account that we use to set up these premium payments. Because again, if we don't know until 8 months goes by, that makes it really hard for us to get things corrected in the individual market. And because there isn't just one invoice to look at, and instead the three of us are providing payroll deduction reports, or, you know, the other reporting that ICHRA Systems provides to us for you guys. It's very important to keep on looking at those monthly to make sure that everybody's premium is indeed coming out like it should. Also to let us know immediately if somebody leaves. What I have seen happen is, in the traditional group world, when an employee leaves an employer, what happens is that person's insurance is ended and they have an opportunity to continue it through state continuation or COBRA. But with an ICHRA, the plan belongs to the employee. So there's been confusion around that for some employers. We just take the payment off. We don't cancel the plan. We just remove the payment. So then if somebody gets a bill, but they haven't told us that they want to end the coverage, you know, luckily we have people like Doug and Jim at Elevate Denver Health that help us with that. But not all carriers do that. And it really is up to the carrier, you know, whether or not they're going to honor backdating coverage, because historically in individual plans, that's not a thing. That's a traditional group insurance thing. So we just want to be really careful. All of the documentation that ICHRA Systems generates for us does explicitly state in the second paragraph, right on the first page, this plan is yours. If you don't cancel it, it's going to continue, right? So that is sometimes a point of contention. We need to really make sure employers are communicating to staff. We're communicating to staff. It's very similar to traditional group, and it's also really different. So we just want to make sure everybody's on the same page, and we can make it as smooth as we can with the education piece in mind.
Yeah. And just to elaborate on that, Kristen was saying, you know, if an employee did leave employment and they forgot, you know, which can happen because you're starting a new job maybe, and that new job's going to have its own coverage. If they didn't cancel their individual plan, that elevated health plans, which is the one we're affiliated with, they will try to accommodate you if you have a timely notice, not at the end of the month, but within, you know, a certain time period, they will refund that to you, which is a great thing that they do, and why we're glad to partner with them. All right, Merida.
Yeah, I'm going to take us a little bit out of the weeds and just come over this general, like, if you're looking at this or you already have it, a clear communication, full disclosures, like we're not promising rainbows and unicorns. There is absolutely the intrinsic value of offering group coverage. If you don't do so already, it's just really hard to find and keep employees these days. If you have already a small group plan, shop it against ICHRA. We reviewed the pros and cons of that on this call, but we each do that, like just one-on-one with you. And it's really just an industry that keeps us all on our toes. It depends on your group size and what is the best fit and where people live and all these sort of different pieces that we've been discussing, and the ICHRA component in other parts of the state with all of these rate increases, the small group and ICHRA rates are almost on parity. They're closer. And there could come a time where small group rates are less than individual, and guess what? We'll just switch your group back over. It's okay to shift with where the most beneficial healthcare spending is. And that there really are just different options out there. Although, if it looks too good to be true, it probably is. There are a lot of people that call and say, can't I just have a catastrophic coverage? And I want to offer my staff a membership to a direct primary care model, which is this neat thing where you pay a membership fee and you could go see a primary care doctor. There is no such thing as a catastrophic plan that will cover you for millions of dollars. It's just not like carriers in the end don't care about like a broken arm and a cataract surgery. They are worried about the big major claims. And so you can't pay $100 a month and have someone there for you for when the big one hits. I think it's great to see that we have more competition in our area, especially with the Elevate Health, Denver Health Plan being offered. Some counties literally only have one carrier to choose from. So in our neck of the woods, it will change who's the most competitive, or is my doctor a network, or helping people choose which ultimately works the best for them. Does the ICHRAs, right? We're not like just by default meeting with each person that has them. They get this link, they go enroll, we're absolutely available to ask. And people don't want to just have to change all the time, or a lot of it's like, let it just go. But with these rate increases, I expect a lot of people who are on these richer level plans to at least peek at what the bronze level plans will be. There's a lot of just fear and unknown in the world right now. The point of insurance is to feel like you are covered and that you are not going to lose your house and that you have access to providers and utilize in-network providers. Doug, I want to just kind of come back to your very first comments, which is the work that the Peak Health Alliance is doing and bringing, like, lowering costs, right? There are just concerned citizens out there that are trying to bring rates down. House passed something, National Congress working on passing things. And then you think, oh, but I didn't use my insurance this year. And it's, and I say, I'm so glad you didn't. And I'm ultimately preaching to the choir, but the carriers are subject to a medical loss ratio. If they don't spend an individual 80 cents of every single dollar that comes in their door, they have to give it back to the members. And it's just a confusing time. And to Lisa, in the medical practice, right? Like, you're just one of the fewer privately owned practices that hasn't been eaten up by but you guys are just trying to keep your doors open. Primary care providers, right? And on the provider side, accepting Medicare, Medicaid, all these different carriers. Is it a group? Are people uninsured, right? I'm curious if you speak to that briefly on, like, is how you even field that.
So it is complex. So I think it was last summer or the summer before, we had a major carrier here in Colorado say, you know what, we're not going to do business in Colorado. And our patients panicked. They were trying to scurry to get other coverage, and so we're also trying to, like, you have people who are ill, they have, chronic diseases, diabetes, whatever. And so that really disrupts their care. And then we have a new thing going on in the industry right now that may not be interesting to you, but it is what I'm living and breathing right now. We have a major carrier, Cigna, who said, hey, we're going to start down coding your bills, doctors, if you don't document every single thing that justifies it. Now, there are many people who think this is illegal, and so there's some lawsuits out there. But we now can see that the doctor can perform all the services, do all the coding, but these big carriers are saying, hey, you know what? If it's not perfect, we're just not going to pay you less. So that's a huge thing. So that means that we really have to look at that building a lot closer. We also know that there, with the whole Medicaid, we balance our practice. We want to support the community. But if we just took Medicare and Medicaid, we could not keep our doors open. So we have to balance that. And it's really hard to hear that the government's getting ready to like get rid of, in essence, in my opinion, get rid of Medicaid in a way. My previous experiences, I worked for a federally qualified health center, which is a huge safety net for healthcare in the US. So to hear that, it's devastating what it's going to do for people who are ill. So there's the downcoding. Then there's also, many people don't know that Medicare has written into the law that says providers will, their fees will go down by 2% every year. So that down by law, we don't get reimbursed. So that reimbursement to a provider goes down by 2%. So that is also a big thing to take into consideration. And I don't want to get too much in the weeds, but there's another aspect of monies that we can get from carriers. And so like Anthem, they have these things called AOCs. And basically they kind of incentivize providers if we can provide metrics that show that we really are getting our patients well. So they come along and they say, hey, if you can keep, this cadre of patients A1C below a certain level, then we'll give you extra money because we're saving it because they're not going to have their leg amputated. So interestingly enough, one of the first things that happened is we had a big program like that cut like within the first 100 days of the new administration. So my practice, we're scrambling to figure out how we can make up that loss of revenue. Because as primary care physicians, we are the front line. Everybody has to see their primary care physician most of the time because they need a referral to whomever. So there's a lot of what we call pajama time. That means that the way the coding system is that when you're in the office, we put all those magic codes in there and we get paid. But the reality is that my doctors do what we call pajama time. They're at home at night going through all their patient records to make sure that they've got the orders written and the referrals to all the right places. And they don't get paid for that. So a lot of doctors don't want to be in primary care. And a lot of doctors don't want to handle all of that. So they'll sell their practices and they'll just be part of a big, hospital system. Not sure if that answered your question, but
super interesting.
Well,
yeah.
We really appreciate you, primary care doctors. You are the backbone of the health system. And thank you so much. Please share our thanks with your clinical staff. And thank you, everyone, for joining today. This has been so informative. Thank you so much to Merida and Kevin and Kristen for what you do for our community and educating people every day. And if you do have questions, please reach out to one of these brokers. I'm also available to help, but they're really the experts. And we just really wish you the best and that you can use this information to your benefit. So thanks for joining today.
Thanks, Doug, for hosting.
Thank you.
Bye.